At the outset, it's a great honor and a privilege for me to have the opportunity to deliver the first Professor P. Ravindran oration in the CME program on extrapulmonary TB. I sincerely thank the organizers of this CME program, particularly Dr. Sanjeev Nair and Dr. Arjun, and the academic members who gave me this opportunity. The topic assigned to me as a kind of opening batsman for all the each system extrapulmonary TB talks that ought to follow is the diagnostic approach. So in the next 35 odd minutes or so, I plan to share with you how I view, in my view, in the year of grace 2021, the diagnostic approach to extrapulmonary tuberculosis. I also state that I have no conflicts of interest to declare. All of us have known TB, have lived with TB, and we don't even dare forget TB. In spite of the new kids on the block like COVID, TB is still there, lurking behind, waiting to pounce back. The problem with TB is if we diagnose it early and treat it effectively, it can not only cure the patient, but eventually institute control of TB in the community as well. However, while it seems so simple, in effect, it doesn't seem so. Dr. Sanjeev has shared with you some of the epidemiological data regarding EPTB. I picked up this from the Global TB report. In the year 2020 report, which is still current, the EPTB constituted about 16% of all the incident cases that were notified. But as you would see in this graph here, this map shows various shades of colors indicating the proportion of EPTB cases are not uniformly distributed at all places. If you look at our own India TB report 2020, well, I'm not providing you any magnifying glass to view this. It would suffice to say that while there is a wide variation across the states, EPTB constituted about 27% of all the notified cases of TB. 15% or 25% number-wise as well as proportion-wise, EPTB is a formidable form of TB to contend with. Because unlike pulmonary TB, where the presentation is relatively more straightforward, EPTB is often obscure, mysterious, and misleading as well. Often, EPTB is a misdiagnosis, a misdiagnosis, or a diagnosis which is delayed. Therefore, it is necessary for us to update ourselves with what's happening in the field of EPTB diagnostics. If you see the organ involvement in EPTB, in individuals who are HIV seronegative or those who are immunocompetent, bulk of the disease is pulmonary TB, and extrapulmonary TB constitutes only about 20%. But in the immunosuppressed, as in late HIV, the disease is more commonly encountered than pulmonary TB. This famous cartoon is from a paper that was published in the year of grace 2004, in the year 2004, and when the IJMR celebrated their centenary celebrations, they did a citation analysis and identified the 13 top-ranking articles published during the 5 decades in the Indian Journal of Medical Research, which incidentally is the journal with the highest impact factor from India. Here, 2020 ranking is 2.375 something. This article was rated as number 8, which in the pre-soft copy submission era, this was one of the last hard copies of the article with hard copy photographs we had submitted. And this was a very memorable piece of work for us, because this was for the first time at an international level a perspective of EPTB, its burden, its diagnosis, its treatment options, treatment duration, treatment outcome definitions were put forward. And I would like to share with you the other good news. I thought this particular article in the expert reviews would be up online today. The article was accepted in May 2021, but in a day or two, this article will be available full text in the expert reviews website. And I request all the postgraduates particularly to go through it, because it is the state of the art with regard to EPTB as we see it today. First, let's get to the basics before we talk of the diagnostic approach to extrapulmonary TB. What is extrapulmonary TB? Like my esteemed chairperson, Dr. Madhu told, extrapulmonary TB is active TB disease involving one or more extrapulmonary focus without pulmonary parenchymal involvement. It is active TB disease. It may involve one or more than one extrapulmonary focus, but there should be no pulmonary involvement concurrently. There are two other terms which are confusing. One is disseminated TB, other is miliary TB. We use these two terms bedside when we take the ward rounds, when we teach postgraduates. These are the clinicians' terms. These are not the program definitions. Disseminated TB is active TB disease that is characterized by concurrent involvement of at least two non-contiguous organ sites, or the demonstration of the bug causing TB in the blood or the bone marrow. Miliary TB is a type or a form of disseminated TB which results from a massive hematogenous dissemination of the tubercle bacilli, which results in tiny discrete foci, usually the size of millet seeds, that is 1 to 2 millimeters, which are more or less uniformly distributed in the lungs and the other viscera. The point to note here, particularly for the young postgraduates, is intrathoracic mediastinal or hilar lymph node involvement, though it is an intrathoracic form of TB, is categorized as extrapulmonary TB when there is no radiological abnormality in the lungs. Similarly, TB pleural effusion is also categorized as extrapulmonary TB if there is no pulmonary parenchymal involvement. If a patient with EPTB focus also has involvement of lung parenchyma, in the program terminology, the patient gets categorized as pulmonary TB. For example, miliary TB is also categorized as pulmonary TB. How do we diagnose extrapulmonary TB? What is the diagnostic approach? Till about maybe 5-6 years ago, the pursuit of the diagnosis or the hunt for the diagnosis of extrapulmonary TB was mostly elimination or wishful thinking or some kind of prediction based on some imaging. Often it would be that when you have eliminated the impossible, whatever remains, however improbable, must be the truth kind of situation. Unlike pulmonary TB, where you have a sputum to test and you say, yes, I have found TB, you have the sputum to monitor, and yes, you say, I have cured TB, and you have again the sputum. If you have it, you can say, yes, I have stopped the treatment of TB. Extrapulmonary TB is not like that. It's mysterious, it's hidden, it's cryptic, it is not in front of your eyes, and there is a lot of confusion with regard to knowing the extent of the disease, knowing when the disease is active, or when to stop the anti-TB treatment. So, keeping this in mind, my approach to extrapulmonary TB diagnosis is asking two questions. This is what I teach my students, and this is what most of the current workers on EPTB aim at. Where is the disease? What is the disease? Where is the disease is answered by the anatomical localization. That is, you examine the patient, you find a lump, you find a bump, you find a peripheral lymph node, you find cutaneous lesions, you find an abdominal lump, and so you find a sinus in the chest, and so on. A meticulous clinical examination gives you a clue to where is the disease. The history and the clinical examination tell you majorly where is the disease. This is ably assisted by the imaging modalities from the chest radiograph through computer tomography to magnetic resonance imaging, now coupled with positron emission tomography, the PET CT, the PET MRI, and also the endoscopic visualization of the various body organs and structures. This tells us where all, to what extent the disease is located. But we need to know what is where, TB or not TB. This is possible by procuring body fluids, the appropriate representative tissue, the histopathological, microbiological, and molecular methods are to be judiciously used to establish the proof of diagnosis of TB, or sometimes not TB when you identify the non-tuberculous mycobacteria or fungal etiology or malignancy or something else. So the diagnosis is a two-pronged, two-step approach. Define where is the disease, to what extent it is involved, and ascertain that it is TB. Let's see how we go about that. It's a good question, because if we do not define that it is TB at the outset, upfront, in the first available opportunity, later on, if it is not TB, the therapeutic implications to the patient are significant and can be damaging as well. So I will share with you one quick example of a prized patient. This child was seen by various pediatricians, dermatologists, and they were going around in circles with regard to what this was. Eventually, there was a referral to our department, and when we saw the patient, it looked like a slightly long duration febrile illness with an xanthomatous rash. The various causes listed in the laundry list in pediatric textbooks were being pursued. Somehow we thought we will do a biopsy of this lesion, and to our surprise, it turned out to be miliary TB, tuberculosis miliaris cutis. This was one of the early lessons we learned, as to never ignore any clinical finding in the pursuit of extra-pulmonary TB, disseminated TB, miliary TB as a clue to the diagnosis. And this was one situation where we really benefited by making the diagnosis early, so that we could start treatment and give relief to this patient. Again, if you see this particular picture, the patient, the clinical photograph in panel G, which is listed there, this patient was diagnosed to have peripheral lymph node TB. He was started on anti-TB treatment based on an FNAC, which showed granulomatous lymphadenitis. And after about 2 months of treatment, the nodes had enlarged in size and they started discharging pus. As this patient was not improving in the PHC level, the patient was referred for further evaluation, and a more detailed evaluation revealed it was not merely a isolated peripheral lymph node TB, but it was something more, with involvement of the lung as well as the intrathoracic nodes and a pleural effusion as well. So seemingly innocuous isolated location of extrapulmonary TB, when carefully evaluated, will reveal the disease extent much more than what is being revealed on a cursory examination. And this is again a lesson for all budding clinicians to keep the wide range of diagnostic disease involvement when you are working with a patient with suspected extrapulmonary TB. This is again a patient who came with a prolonged fever. The point of interest was in the outpatient service, the patient had brought an X-ray along with him. That X-ray was showing some suspicion of probable miliary disease, which prompted immediately the fundus examination, and the bedside examination showed choroid tubercles. Later on, imaging confirmed miliary TB, and the CNS imaging confirmed CNS tuberculomas, TB meningitis as well. So extrapulmonary TB is intriguing. It is widespread, often wide and well disseminated, but one should be able to document the disease extent as well by a thorough examination. I am sure the subsequent speakers will be highlighting the role of imaging in various forms of extrapulmonary TB, neurological, gastrointestinal, lymph node and all. I'm not going to go to describe the great virtues of ultrasound versus CT versus MRI versus MRI spectroscopy and all, which I believe is all known to you. But I want you to focus on the PET CT and PET MRI in the disease extent mapping and for instituting the stopping rule. This is the pre-treatment whole body PET CT of a patient with extrapulmonary TB. See the intrathoracic, the lymph nodes which are enlarged. The disease activity is indicated by a bright light indicating increased uptake. This is the pre-treatment, the paratracheal and subcarinal nodes pre-treatment. The diagnosis was confirmed by a CT-guided lymph node biopsy and gene expert testing of the biopsy specimen that showed M. tuberculosis complex and R resistance not detected. So the patient received the classical first-line anti-TB treatment. At the end of treatment, when the PET CT was repeated, please see these yellow lights are all switched off here. These nodes are not seen anymore. These nodes have disappeared. So PET CT and PET MRI offer a great potential to tell you not only where the disease is, but also to tell you what is the extent of the disease. It will also tell you that the residual lesion which is there at the end of treatment, is it active disease wherein you expect an increased uptake, or is it merely a scar which can sometimes be more than 1 centimeter in size. So this is a new option available to us for the ante-mortem diagnosis of cryptic, occult, hidden extrapulmonary TB, as well as defining the disease extent and defining the stopping rule. This is another patient with intrathoracic lymph node TB. This is a patient with non-specific aortoarteritis due to TB who was treated with anti-TB treatment. This is the pre-treatment PET CT. This is the post-treatment PET CT, which shows the uptake is switched off. Yes, now we can stop the anti-TB treatment. Disease extent definition, disease activity definition, and stopping rule. These are the advantages of PET CT and PET MRI. They are not yet widely available. Who thought that gene expert will be available at a district level in India 5 or 10 years ago. In 2012, 2013, we used to salivate and say, oh, there is something called Gene Expert. Today, we have used Gene Expert not only for diagnosis of TB, but TB helped the diagnosis of COVID as well. So anything can happen if there is a will from the administrators. And I do expect that we will have access for the disease geographic extent mapping by the PET imaging soon across the country. It's a dream which I hope I will live to see. Now, what is the diagnostic yield of the conventional methods for the diagnosis of extrapulmonary TB? This table with very tiny letters is not meant for you to read every letter. When the publication comes online in a day or two at the expert review site, you can go through it in detail. But needless to say, the conventional diagnostic methods of cell count, biochemical characteristics, ADA, interferon gamma, T-spot TB, histopathology coupled with culture and all, the diagnostic yield, even for body fluids, is suboptimal and not greatly encouraging. We do need to go through the ritual, but often the results are not conclusive. And in this background, the index TB guidelines were developed between 2013 and 2015, when they were formalized and finalized. And these index TB guidelines are the first evidence-based guidelines on the diagnosis and certain treatment issues related to extrapulmonary TB. I'm delighted that in the inaugural, Professor Sharma's words, which were prophetic, which I had the good fortune of listening to him say a million times again and again when we worked on the index TB guidelines. This is the brainchild of my mentor and my teacher, Professor Sharma, and we carried this palanquin as the palanquin bearers during the time. And this was the famed release program which was held in the boardroom at the All India Institute in August 2016. This is Paul Garner from UK. We have Professor Sharma and all other giants, Professor Rajendra Prasad, Dr. Soumya and all, who had released the guidelines. I was also part of this guideline making team. Thereafter, the full guideline as a policy document appeared in the Indian Journal of Medical Research. And as on date today, these are the only evidence-based guideline for extrapulmonary TB. This was the first time where some tangible, dependable, reliable, reproducible, repeatable data were available for at least some forms of extrapulmonary TB like the lymph node, the pleural effusion, and the CSF in TB meningitis regarding the use of Xpert MTB RIF. For lymph node TB, the index TB guidelines told it must be used as an additional test to the conventional methods. For TB meningitis, it was recommended to be an adjunctive test for TB meningitis. And the important message there was a negative expert won't rule out a TB meningitis, but a positive result will rule in a TB meningitis. Clinicians should not withhold anti-TB treatment based on one test result, but should take into account the whole clinical picture. For pleural TB, routine use in a programmatic mode was not encouraged. Thereafter, in the last 3-4 years, some more data had been pulled in, and if you look at the yield of the extrapulmonary TB by conventional diagnostic methods, they have low sensitivity but high specificity. The smear yield is lower. The conventional culture yield too is not great, 25 to 75%. Wide variation, methodological issues. Liquid culture yield was somewhat marginally better, but when we applied the molecular diagnostics, Xpert and Xpert Ultra and the LPA, the sensitivity was somewhat similar and specificity was good, but rapid diagnosis was very much possible. At the time of publication of this article, I have not seen TrueNat applied for the diagnosis of EPTB. Some work may be going on, so I can't comment on that. So if you look at the pooled sensitivity and specificity of the Xpert MTB RIF, that is the gene expert for CSF lymph node, aspirate lymph node, biopsy for pleural fluid, urine, bone or joint fluid, peritoneal fluid, and pericardial fluid, and so on. The pooled sensitivity is little less. Specificity is pretty impressive, indicating that this can be used as upfront diagnostic tests wherever possible. And this comparison was with a microbiological reference standard. However, if you take a composite reference standard, which includes in addition to the testing, the ancillary tests like biochemical tests and so on, if you take the response to anti-TB treatment also to define the diagnosis of TB, the performance with regard to the pooled sensitivity and specificity, both in terms of the global data and Indian data, are impressive. This is a very significant table because this Indian data performance, for example, pooled sensitivity in terms of CSF has been quite good. Maybe we are using more aggressively, picking up more cases from India. The specificity is very impressive, at least for certain forms of lymph node, certain forms of extra-pulmonary TB like CSF, lymph node, and so on. We have tangible, reliable, and dependable data with regard to ascertaining the diagnosis. So, a word about serological testing. Yes, hallelujah, no more serological testing. It's been banned for the last 10 years. Some young postgraduates may not have known that there were serological tests and they were banned. They should remember again that change is the only permanent thing in life, and change in the way we ascertain the diagnosis has been undergoing a change. So it's all for good, and no serological testing for extra-pulmonary TB as well. So what would be the diagnostic algorithm? This is the diagnostic algorithm we have given in the publication, which you all should read. When you have a clinical suspicion of extra-pulmonary TB, physical examination clue to the site of disease involvement, like peripheral lymphadenopathy, skin lesion, image-guided or endoscopic localization should be done, and an attempt should be made to procure the appropriate tissue or body fluids for diagnostic testing. The tissue or body fluid is available, accessible, tappable, biopsyable, FNACable. Then the specimen is collected, the Xpert MTB and liquid culture, and then DST are done. And the cytopathology, histopathology, and the body fluid testing is done. You detect MTB, you don't detect MTB. And if you don't detect MTB, the algorithm goes on repeating the Xpert on a fresh specimen and so on. If the body fluid is not available, do other diagnostic testing, for example, test for bone marrow examination, aspirate, culture, and so on, and look for an alternative diagnosis. So eventually you end up with bacteriologically confirmed EPTB or a clinically diagnosed EPTB. This is a diagnostic algorithm, current, relevant with the present day technology. Tomorrow it may change. And we presently are working on this algorithm. And at the end of the diagnostic workup, how do we define extrapulmonary TB? Extrapulmonary TB case has three categories: presumptive, bacteriologically confirmed, and clinically diagnosed cases. Presumptive patient is a patient with symptoms and signs of EPTB who needs to be investigated. We don't call them suspect anymore, as if the word suspect is used with some negative meaning. So the experts felt that presumptive is a better word than EPTB suspect. Bacteriologically confirmed case is a patient who has a microbiological diagnosis of EPTB based on a positive microscopy, culture, or a validated PCR-based test like the Xpert or the LPA. A clinically diagnosed patient is a patient with negative microbiological tests for TB and strong clinical suspicion and other evidence of EPTB, such as compatible imaging findings, histological findings, ancillary test findings, or response to ATT. Here, when we talk of the word microbiological test, it includes microscopy, culture, and validated PCR-based tests. Validated PCR-based test means the CB-NAT and its congeners. In-house PCR tests have poor reliability, repeatability, reproducibility, and as on today, they are not considered as validated PCR-based tests. So what is the take-home message for extrapulmonary TB diagnostic approach? We should remember that the clinical presentation of extrapulmonary TB is varied. Fever and symptoms of TB toxemia may not always be present, or fever may be the only manifestation of an occult sign of extrapulmonary TB. The atypical manifestations delay the diagnosis and delay the start of anti-TB treatment. Therefore, the high index of clinical suspicion is required for the early diagnosis of extrapulmonary TB. Imaging and endoscopic visualization provide valuable clues to where the disease is present. Testing of the tissue or fluid will tell us whether it is TB or not. Wherever feasible, in addition to the molecular methods of diagnosis, the gene expert, various generations, LPA, mycobacterial culture and sensitivity testing in an accredited, recognized laboratory must be attempted, because starting anti-TB treatment with or without corticosteroids, where indicated, early in the course of disease can be life-saving. I conclude my presentation paying my respects to my teacher and mentor, Professor Sharma, because of whom I am here today. I once again thank the State TB Cell of Kerala, my friend Dr. Sanjeev and Dr. Arjun, for giving me this opportunity to share my thoughts and to deliver this prestigious oration as the first recipient. And I thank you all for your patient hearing. Namaste.